Now we come to our last talk of the session by Dr. Girija, Senior Consultant in Glaucoma and Cataract at Little Flower Hospital, Angamali. Dr. Girija is going to speak to us about management of angle closure and challenges faced during cataract surgery in shallow AC. Over to Dr. Girija.
Good morning, everyone. Management of angle closure glaucoma and challenges in cataract surgery in shallow anterior chamber. So these are difficulties that we commonly face. A 60-year-old female presented to a casualty. She was referred from a nearby hospital. She was being treated there by a physician for headache and vomiting and eye pain. Later only she complained about the eye pain and they referred her to us. And she presented with all the typical features of acute angle closure. That is, there was corneal edema, circumcorneal congestion, flat anterior chamber and a mid-dilated non-reacting pupil, and the IOP was in the 60s. Gonio was difficult to do in the affected eye, but the other eye showed occludable angles. So this acute angle closure glaucoma, it's a emergency, ophthalmic emergency, which is potentially blinding, and it has to be treated. Timely treatment is very important. What is the mechanism of intraocular pressure rise in angle closure glaucoma? In acute attack, there is a sudden blockage of the trabecular meshwork, and it is by the appositional closure or the synochial closure. So when it's reversible, it's appositional. But after an acute attack, sometimes the synochiae may remain permanent. It can even extend through the circumference, and it can result in a chronic angle closure glaucoma. So that is why even after doing a PI, you have to follow up the patient and see whether the disease is progressing. And medically, the treatment is based on reducing the acosumor production or increasing the outflow, and also by reducing the volume of the acosumor and the vitreous by using the acetazolamide in the hyperosmotic agents and the various topical anti-glaucoma medications, and along with the most important, the topical steroids. But the treatment of choice is laser peripheral iridotomy. And in an acute attack, there is no doubt you have to do once the diagnosis is established, because it will help to relieve the pupillary block, and also it will prevent future attacks. But after the PI, always do a gonio, see whether the angle has opened and see whether the IOP is controlled. And if the IOP is persistently high, then again you have to start anti-glaucoma medications and regularly follow up the patient. The various surgical treatment options are mentioned here. Surgical iridectomy usually nowadays not done because LPI has largely replaced it, but sometimes because of the unresolving corneal edema or severe iris edema and the inflammation is not getting controlled with the steroids, you may have to do the surgical iridectomy, especially in case of secondary angle closure where the following retina surgeries, you may get persistent inflammation and the PIs that you do get continuously blocked. So repeated closure and the patient presenting with acute features. Then you have to do a surgical iridectomy. Then along with other procedures like TRAB and others, you do a surgical PI. Then goniosynochial lysis is another procedure where there is synochiae which has to be released. Along with cataract surgery, if there are synochiae, you can mechanically strip the PAs away from the trabecular meshwork using viscoelastics or an irrigation cyclodialysis spatula under direct or indirect visualization. But there is limited evidence about its effectiveness. Only thing is that can be done along with cataract surgery. And trabeculectomy is done only in cases with uncontrolled IOP with maximum medical treatment, and there is in spite of the PI. And the synochiae is extending. If it's more than 190, usually you have to do a trabeculectomy. And if the patient is showing poor compliance and allergies, that's also very common nowadays, allergy to the various medications. So you may have to do a surgical treatment. And it has to be a surgical PI is a must in an angle closure glaucoma. Otherwise, the patient can develop a malignant glaucoma later. And also the use of intraoperative antimetabolites is also advised, so that the surgery result can last longer. The newer options are like the minimally invasive glaucoma surgeries. The various options are there, and these are nowadays being tried along with phacoemulsification. Any procedure can be combined, and available evidence suggests that cataract surgery in combination with mix can be safely and effectively performed in angle closure, but long-term studies are required to see the results. GDs are indicated when the trabeculectomy fails. But only thing is that the tube can result in placement of the tube in the anterior chamber. It can cause endothelial cell loss. So in pseudophakic eyes or aphakic eyes, you can place them safely behind the iris, but the problem comes in phakic eyes. The cyclodestructive procedures are indicated in end-stage diseases with poor visual potential and symptomatic patients. It's a destructive procedure, and there is always remember that in any surgical procedure in an angle closure patient, it can lead to a aqueous misdirection syndrome, which has to be properly managed medically with cycloplegic mydriatics and steroids. When there is coexisting cataract and glaucoma, the debate is whether to do a phaco alone or a phaco trap. Always see that when angle closure glaucoma with an uncontrolled IOP, you have to choose whether to do a trap alone or to do a phaco trap. So if it's very high IOP, it's better to do a trap first, control the IOP, later followed by phacoemulsification. And when there is no cataract with uncontrolled IOP, better to do a trap alone. A lens extraction is again, never do a clear lens extraction, because as Dr. Roni has clearly demonstrated, the role of lens vault is not that important in Indians. So you don't have to do a clear lens extraction, but cataract if present, even if it's an NS 1 to 2, it's better to do, because otherwise the patient may have to undergo a second procedure. What are the challenges that we face when we do a shallow AC cataract surgery in a shallow anterior chamber? This is actually a very has to be done very carefully because of the limited surgical, the working space is very limited because the phaco probe is very close to the corneal endothelium and endothelial cell loss can occur. And even because these eyes are smaller, and even a standard sized incision can cause astigmatism, more astigmatism, and so there is poorer postoperative refractive predictability. And these are the various causes of the shallow anterior chamber. Usually what we see is a short hyperopic eye, but it can be other conditions like microphthalmos or nanophthalmos. Always do a thorough preoperative evaluation. That's very important. Do a proper gonioscopy and see whether the angle has opened or not. Otherwise, take the necessary precautions. And a thorough slit lamp evaluation is required, and do a specular microscopy. Biometry is very important here, and you have to take the axial length, IC depth, and IOL power. And UBM also can aid in diagnosing an ANOF if the axial length is less than 21. And preoperative subtle UV effusions, if you detect in UBM, you can treat them before cataract surgery. And the axial length biometry, there are frequent errors in the axial length measurement in short eyes, so that you have to take care. And accurate prediction of the effective lens position is also very difficult in short eyes. And high power lenses, they can have some errors up to plus or minus 1 diopter. So you can use either the Hofeque formula or the ACRS website. And even 1 millimeter error in a normal eye can induce 3 diopter error, but in a short eye it becomes around 4 to 5 diopters. And it's better to put foldable lenses in the small capsular bag. And the intra-op challenges and solutions. So do a laser PI before surgery, because it will open up the angle and it will increase the anterior chamber depth and release the surgical maneuvering. So, and if you cannot do a PI, like in a phacomorphic glaucoma, always dilate on table. Don't do a PI, but dilate on table and you can proceed. And any posterior synechiae, they release them using viscoelastic or saline. And always stain the capsule, because it will reduce the elasticity and it will improve the visualization, and it will help you not so that the rhexis will not run away when you are doing. And always inject a high viscosity OVD to create and maintain space for rhexis, and it will also help to flatten the anterior capsule, because it will be rounded in most of these cases. So it will flatten them so that you can do a rhexis easier. And when you are doing phaco, always trench the central nucleus and clear the central part so that the phaco probe will be away from the corneal endothelium. At least that much of injury you can reduce. And when you are always during all procedures, inject visco and deepen the anterior chamber. And when you're implanting the IOL, again inflate the AC and the capsular bag and inject them safely. And after IOL implantation also, wash the OVD thoroughly from the anterior chamber as well as from behind the IOL. So these are the small precautions that can help you when you are doing in a shallow anterior chamber. So the take home message is PACS is not all cases require PI, but In acute angle closure, don't forget to do PI in both the eyes. And regular yearly follow-up after PI in PACs is always advisable. Do gonio after PI and always dilate after PI. And do a thorough fundus examination. And thorough pre-op evaluation, accurate biometry and specular microscopy before surgery. And control the IOP before surgery. That can prevent occurrence of malignant glaucoma. And use high viscosity OVDs, but wash them thoroughly before completing the surgery. Thank you.
Thank you, madam, for the